Welcome. In this session, we are going to look at the white matter of cerebrum, and by the end of this session, you should describe the type of fibers in the cerebral white matter. You should also fully describe the internal capsule, and we look at some clinical correlations. Welcome all. My name is Forceps Major, and I'm the UREDactor. So, types of fibers in the cerebral white matter. The fibers of the white matter connect the various parts of the cerebral cortex with each other to the various parts of the central nervous system. They are usually classified into three types on the basis of the types of connection they provide. So these fibers can either be association fibers, commissure fibers, or projection fibers. We will look at each and every type. So let's start with association fibers. Or first let's have a look of this diagram. You can see these are the cerebral hemispheres. There is this side and this side, the left and the right. You can see there are some fibers which are connecting areas, they are connecting areas in the same hemisphere. They are intrahemispheric fibers. These are the association fibers. Then there are others which connect similar areas of one hemisphere to the other. These are interhemispheric fibers, or the commissure fibers. Okay. Then we have other fibers which are connecting the cerebral cortex to subcortical areas and to the spinal cord or the brainstem or the brainstem. These are the projection fibers. So those are the three types of fibers. Let's look at each and every type individually. Association fibers. Now, the association fibers interconnect the different regions of cerebral cortex in the same hemisphere. So they interconnect different regions of the cerebral cortex in the same hemisphere. So they are intrahemispheric fibers. They are of two types. They are either short association fibers, also known as the arcuate or the U fibers, which usually interconnect the adjacent gyri by hooking around the sulcus. Hence, they are also called arcuate. So, short association fibers interconnect adjacent gyri. So then we have long association fibers, which travel for long distances and interconnect the widely separated gyri or gyri of different lobes. So you can find the long association fibers can connect gyri of a frontal lobe with the gyri of occipital lobe. So they are long. The long association fibers are usually grouped into bundles, and examples of such include examples of the long association fibers include cingulum. Cingulum is also the limbic association bundle. We also have the uncinate fasciculus, the superior longitudinal bundle, the inferior longitudinal bundle, and the frontal occipital bundle. Let's have a look of this short. So you can see these are the short association fibers. They are interconnecting adjacent gyri. They just hook around a sulci. Then we have the long association fibers, which include these uncinate fasciculus. Okay. Then we have the inferior longitudinal fiber, which is interconnecting the temporal lobe here and the occipital lobe. Then we have the cingulum here. Cingulum. Okay. This is very important, especially in the limbic system. Okay. Then we have the frontal occipital bundle here, as the name suggests, connects the frontal lobe to the occipital lobe. Then we have the superior longitudinal bundle, which will lie superficial to the frontal occipital bundle. So the frontal occipital bundle and the superior longitudinal bundle, they interconnect the same areas. They are only separated from each other by the internal capsule. We will look at that. But these are the long association fibers. So let's look at the commissure fibers now. The commissure fibers interconnect identical or corresponding areas of the two cerebral hemispheres, i.e. they are interhemispheric fibers from one hemisphere to the other. Okay, so The bundles of such fibers are termed commissures. The important commissures of the brain are as follows. Corpus callosum, the largest commissure fibers. Then we have anterior commissure, posterior commissure, the hippocampal commissure, also known as the commissure of phonics. Then we have the habenular commissure. Now, note this, the commissure fibers are essential for interhemispheric transfer of information for bilateral responses and learning processes. So you can find, if you learn to do one thing with, say, the left hand, the right hand will automatically know to do that, thanks to these commissure fibers, okay? If you learn to kick the ball with the left foot, the right foot will also learn to kick the ball, but you will not have trained the right foot. Due to the commissure fibers, there will be interhemispheric transfer of information. Now, the primary visual, now note this, the primary visual area and the hand region of primary somatosensory area of cortex have no known commissure fibers. So the primary visual area and the hand region of primary somatosensory area of cortex, they don't, there is no interhemispheric transfer of information between those two areas because there are no commissure fibers between those two areas. So that is important to note. Now, let's look at the corpus callosum. Now, the corpus callosum is the largest commissure of the brain. It usually connects the cerebral cortex of the two cerebral hemispheres. Since it connects the neocortex, remember, is the has 6 histological layers. It attains enormous size in man. Remember, neocortex is most developed in man, so man has the largest corpus callosum. It is usually 10 centimeters long, nearly half of the anteroposterior length of the hemispheres, of the cerebral hemispheres. It consists of about 300 million fibers. You can see how enormous it is. Then the corpus callosum connects all parts of the neocortex of the two hemispheres, except for the lower and anterior parts of the temporal lobes, which are usually connected by the anterior commissure. Okay, now let's look at the parts of the corpus callosum. The corpus callosum is divided from before backwards into 4 parts. It has a rostrum, a genu, a trunk or a body, and a splenium. This is the rostrum. Then you have a genu here. Then you have a body of the trunk. Then the splenium here. Okay. Then you can see here is the phonics, and these two phonices communicate with each other via the hippocampal commissure, or the commissure of the phonices. Then the corpus callosum is connected to the phonics by the septum pellucidum. Then let's look at each and every of these parts of the corpus callosum. Now, the genu. It is the thick curved anterior extremity of the corpus callosum, which lies 4 centimeters behind the frontal pole. Genu forms the anterior boundary of the anterior horn of the lateral ventricle. Now, the fibers of the genu usually sweep forwards on either side into the anterior parts of the frontal lobe, forming fork-like structure, which is known as the forceps minor. So, fibers of the genu usually sweep forwards on either side into the anterior parts of the frontal lobe, forming the forceps minor. So there is forceps minor, which arises from the fibers of the genu. Then the rostrum. The genu usually extend downwards and backwards as a thin prolongation to join the lamina terminalis, forming rostrum of corpus callosum. This lamina terminalis, when you do your embryology, lamina terminalis refers to the most cranial. This is the cranial end of the neural tube. Okay, the most cranial end of the neural tube forms the lamina terminalis. Now the rostrum forms the floor of the anterior horn of lateral ventricle, and its fibers extend inferiorly to connect the orbital surfaces of the two frontal lobes. Now the trunk. The trunk is the main part of the corpus callosum between its thick anterior genu and the posterior extremities. So it lies between the genu and the splenium. Its fibers connect most of the frontal and anterior parts of the parietal lobes of the two cerebral hemispheres. Now, the central parts of the corpus callosum forms the roof of the central part of the lateral ventricle. Okay, then finally the splenium. The splenium is the massive posterior extremity of the corpus callosum, which lies 6 centimeters from in front of the occipital pole. It overhangs the thalamic pulvinus, the pineal gland, and the tectum of the midbrain. So it lies superior to this, to the thalamic pulvinus, the pineal gland, and the tectum of the midbrain. Remember, if you have done the midbrain, the tectum of the midbrain has 4 swellings: the corpora, quadrigemina, or the colliculi. Now, the fibers of the splenium connect the posterior parts of the parietal lobes and temporal and occipital lobes of the two hemispheres. Now, the fibers connecting the occipital lobes usually sweep backwards on either side above the calcaline sulcus, forming a large fork-like structure, the forceps major. So forceps major refers to those fibers connecting the occipital lobes which sweep backwards on either side above the calcaline sulcus. That is forceps major. But forceps minor, fibers sweep forward on either side into the anterior parts of the frontal lobes. Now, the forceps major usually form a swelling in the upper part of the medial wall of the posterior horn of lateral ventricle, which is known as the bulb of the posterior horn. So maybe now we look at that using this diagram. Can see these fibers are somewhat they are sweeping forward. This is your forceps minor, and this is your genu. So forceps minor is from the genu, but forceps major is from the splenium of corpus callosum. Okay, then yeah, those are maybe parts. You can look at this, the answers, if you want to know the other parts. Then let's look at the same. This is the corpus callosum here. This is your septum pellucidum. This is your fornix. These are your lateral ventricles, and you can see for most of the part, the corpus callosum forms the roof of the lateral ventricle. Especially now, this is the trunk of the body. You can see it is connecting this hemisphere to this hemisphere. Then this is your anterior hoid commissure here. This anterior hoid commissure. Okay. Now let's look at the anterior hoid commissure. Now, the anterior hoid commissure is a small round bundle of hoid fibers which crosses the midline in the upper part of the lamina terminalis, immediately in front of the anterior column of the fornix and the interventricular foramen of Monroe. Now, the anterior commissure consists of 2 components. It has a larger posterior neocortical component. This larger posterior neocortical component usually connects the lower and the anterior parts of the temporal lobes, which are neocortex, which are neocortical in nature, if I can say like that. So, and it also has a smaller anterior paleocortical component, which interconnects the olfactory region. Remember, the paracortex consists of the parts of the cerebral cortex which consist of 4 or 5 layers. Okay. Then archicortex 3 layers. Then neocortex 6 layers. So those olfactory regions refers to the olfactory bulb, olfactory tubercle, olfactory trigone, etc. of the 2 hemispheres. Okay, maybe go back to, you see the anterior hoid commissure. Here it is. Here it is the anterior hoid commissure. Okay. Now let's look at the other commissures. The posterior commissure, it is a slender bundle of white fibers which crosses the midline through the inferior lamina of the stalk of pineal gland. It usually interconnects the superior colliculi, pretector, and interstitial nuclei of two sides. Okay, this is interstitial nuclei. You can find some books calling them the interstitial nuclei of Agile. Okay, that will also apply. So please note that the posterior commissure crosses the midline through the inferior lamina of the stalk of pineal gland. Then we have habenula commissure, which is also a slender bundle of white fibers that which crosses the midline through now the superior lamina of the stalk of pineal gland and usually interconnect the habenula nuclei of the two sides. Then we have the hippocampal commissure or the commissure of fornix, which interconnects the crura of fornix and thus the hippocampal formations of the two sides. Okay, now we are done with commissural fibers. Now let's look at projection fibers. Now these projection fibers connect the cerebral cortex to the subcortical centers. Subcortical centers refers to the corpus striatum, parts of the basal ganglia, thalamus, brainstem, and the spinal cord. These fibers are of two types. They are either corticofugal, which go away from the cortex. They are cortical efferents to centers in other parts of the central nervous system. Then we have corticopetal fibers, which come from the cerebral, which come to the cerebral cortex from other centers in the central nervous system. So those which go towards the cortex are corticopectal. Then away from the cortex are corticofugal. Now the projection fibers of neocortex constitute the corona radiata and the internal capsule, where those of the allocortex refers to the paleocortex and the archicortex, constitute the fimbria and the fornix. Now the most important bundles of projection fibers are internal capsule and fornix. Today we will look at internal capsule. Fornix we will look at another time when discussing the hippocampal formation. Now let's look at the internal capsule. Now internal capsule is a compact of projection fibers between the thalamus and the caudate. It is between the thalamus and caudate nucleus medially. So the medial relation of the internal capsule refers to the thalamus and caudate nucleus and lentiform nucleus laterally. Now these fibers fan out rostrally or cranially to form the corona radiata and condense caudally to continue as the crus cerebri of the midbrain. Now the ascending stroke corticopectal stroke sensory and descending stroke corticofugal or motor fibers of the internal capsule chiefly interconnect the cerebral cortex with the brainstem and spinal cord. So fibers which move from the cerebral cortex to the spinal cord, they must pass through the internal capsule. Now, these fibers are mainly responsible for sensory and motor innervation of the opposite half of the body. Why the opposite half? Because they decussate. Okay, they usually cross the midline. They decussate mainly. They usually decussate, that is, because of the high concentration of motor and sensory nerve fibers within the internal capsule. Even a small lesion may produce a widespread paralytic effect and sensory loss in the opposite half of the body. Because these fibers are usually condensed, they are highly concentrated in the internal capsule. If you have a lesion there or an injury, most of these fibers will be damaged. So there will be a widespread paralytic effect and sensory loss in the opposite half of the body. Okay, then let's look at this. This is the internal capsule. Okay, this is the internal capsule. This is the internal capsule here. This is the internal capsule. Now this is your thalamus. Okay, this is your thalamus here. This is your thalamus. This is your caudate nucleus. This is the head of caudate nucleus. This is your lentiform nucleus here. Lentiform nucleus is composed of which is composed of globus pallidus here and the putamen. Okay, this now you can see the thalamus and the caudate nucleus are aligned medially and the lentiform nucleus laterally. Then I want you to see something. You can see this structure labeled number 16. That is your external capsule. Then we have another capsule known as the extreme capsule. So here I want you to see something. You can see this gray matter here. This a thin one, just a thin one. That is your claustrum. That is known as the claustrum. Now the region which is lying medially, medial to the claustrum but lateral to the lentiform nucleus, that is your external capsule. Then we have the region which is lying lateral to the claustrum, this thin slender gray matter here, but medial to the insular lobe, the lobus insularis, so known as the lobus insularis. Now this is the extreme capsule. Then the internal capsule has parts as shown here. There's an anterior limb, this one or this one. It has a genu, this one or this one here. It has a posterior limb, this one, this area here. Then it has a retrolentiform part, this part here, retrolentiform. Then it has also another part known as sublentiform, which is found beneath this lentiform nucleus. It is below, so it is not visible here. Okay, those are the parts of the internal capsule. Now let's look at the constituent fibers of the internal capsule. Now the anterior limb, its motor fibers are the frontopontine fibers. Its sensory fibers are the anterior thalamic radiation. Genu, it consists of the frontopontine fibers, corticonuclear and corticospinal fibers for head and neck. And sensory fibers are the superior thalamic radiation, anterior part only. So the anterior part of the genu is the one which will have the superior thalamic radiation. Then the posterior limb will have frontopontine fibers, corticospinal, the pyramidal fibers for upper limb, trunk, and the lower limb, and also the corticorubral fibers. Sensory fibers in the posterior limb are the superior thalamic radiation. Then the retrolentiform part will have the parietopontine and the occipitopontine fibers, where the sensory fibers in the retrolentiform part is the posterior thalamic radiation or the optic radiation, or the other name of optic radiation is geniculocalcaline tract. Then sublentiform part has parietopontine and temporopontine fibers as the motor fibers, and the inferior thalamic radiation or the auditory radiation, also known as the geniculocortical tract. Okay. Now let's look at that. You can see this is the anterior limb, the genu here, posterior limb, then retrolentiform part, then sublentiform, the one in phantom here. Okay, you can see the constituents. Okay, and I want you to see how the corticospinal fibers are arranged. You start with the head and neck, which are in the genu, then the upper limb for upper limb, then the trunk, then the lower limb and in the posterior limb, then the corticorubral there. Okay, then you can see here in the anterior limb, you have the anterior thalamic radiation, sorry. Then here we have the superior thalamic radiation, but only the anterior part is found in the genu, but most of it is found in the posterior limb. Okay, then you can see the auditory radiation in phantom here, the one in dashes, is in the sublentiform part. Then in the retrolentiform part, you have the optical radiation or the geniculocarcaline tract for the posterior thalamic radiation. Now, blood supply to the internal capsule is important. Now, blood supply is by the medial and lateral striate branches of the middle cerebral artery. Now, one of the lateral straight branch is larger and more frequently ruptured. It is often termed as Cachot's artery of cerebral hemorrhage. Now, it usually enters through the anterior perforated substance and supplies the posterior limb of the internal capsule. Then you have straight branches of the anterior cerebral artery. One of these branches is larger and usually takes a recurrent course, hence it is known as the recurrent artery of Hübner. It arises just proximal to the anterior communicating artery, runs superior to the optic chiasma and penetrates the anterior perforated substance to supply the genu and the anterior limb of internal capsule. We also have central branches of the anterior choroidal artery supplying the subretiform part. Then you have direct branches from the internal carotid artery which supply the genu. We also have central branches of the posterior communicating artery. Then we have posterolateral central branches of the posterior cerebral artery which usually supply the retrorentiform and the subretiform parts of the internal capsule. Maybe a diagrammatic diagram will help some of you. Here you can see the recurrent artery of Hübner from the anterior cerebral artery. Then we have from the middle cerebral artery. Here you have straight branches here. Then this one of it which supplies the posterior limb is susceptible to hemorrhage and it usually ruptures, so it is known as the Cachot's artery of cerebral hemorrhage. Then you can see some branches from the posterior cerebral artery. Okay, then you can see some direct branches from the internal carotid artery which supply the genu. So clinical correlations. Now, damage to the internal capsule due to hemorrhage or infarction leads to loss of sensation and spastic paralysis of the opposite half of the body, or the contralateral hemiplegia. Now, the hemorrhage commonly occurs due to rupture of the artery of cerebral hemorrhage, also known as the Cachot's artery of cerebral hemorrhage, which supplies the posterior limb of the internal capsule. Now, the spastic paralysis of the opposite half of the body occurs due to involvement of the pyramidal and extrapyramidal fibers of the upper limb, the trunk, and the lower limb. Now, rupture of Cachot's artery of cerebral hemorrhage is the most common cause of hemiplegia, the contralateral hemiplegia. Now, involvement of the recurrent artery of Hübner due to thrombosis or rupture results in paralysis of the face and the upper limb on the opposite side of the body because of the involvement of the corticonuclear, the corticobulbar fibers in the genu and adjacent pyramidal fibers in the posterior limb of the upper limb. Lesions of the posterior 1/3 of the posterior limb and the sublentiform and retrolentiform parts of the internal capsule usually lead to visual and auditory defects. Visual defects, hemianopia, or loss of hearing in the auditory defects. These lesions are usually occur due to the thrombosis of the anterior choroidal artery, which is a branch of the internal carotid artery. Then let's look at the last one, the split brain syndrome. Now, if the corpus callosum is congenitally absent or sectioned surgically, each cerebral hemisphere becomes isolated and patient responds as if he or she has two brains, a condition known as split brain syndrome. Now, this was carried out using monkeys, where the severance of the corpus callosum in young monkeys produces split brain syndrome, such that if they are trained to perform a task with one hand, they are unable to repeat the same act with the other hand, because there is no interhemispheric transfer of information. Now, lesions to the anterior corpus callosum usually result in akinetic mutism and tactile anomia, whereas lesions in the posterior corpus callosum result in alexia without agraphia. Please note that. Now, thank you for your attention, and please subscribe for more anatomy and biochemistry content. Thank you.